Asthma and chronic obstructive pulmonary disease, COPD, are two prevalent lung disorders that often present with overlapping symptoms but have different underlying causes and disease courses. Both conditions can cause shortness of breath, wheezing, and coughing, making it challenging for people to engage in their daily activities without proper management. However, asthma is commonly characterized by reversible and intermittent airway obstruction and is often associated with allergies and an exaggerated response of the airways, while COPD, which includes emphysema and chronic bronchitis, is typically progressive, with persistent airflow limitation, mainly due to long-term exposure to harmful particulates or gases. Treatment for asthma and COPD varies. Asthma is managed with inhaled corticosteroids and bronchodilators, while COPD may require additional therapies such as pulmonary rehabilitation and continuous oxygen therapy. Asthma can develop at any age and is often influenced by genetic and environmental factors, whereas COPD risk increases with age and is strongly associated with smoking. Here are detailed aspects of the disease, including diagnostic differentiation through spirometry, which measures lung function and helps distinguish between the two conditions. Affected lung function, reversible obstruction versus irreversible airflow limitation. In distinguishing asthma from COPD, chronic obstructive pulmonary disease, via spirometry, the key lies in the nature of the airflow obstruction. Asthma is typically characterized by reversible airway obstruction, whereas COPD exhibits irreversible airflow limitation. In practical terms, this means that in asthma, spirometric values such as FEV1, forced expiratory volume in 1 second, significantly improve post-bronchodilator inhalation, reflecting the reversible component of airflow obstruction. However, in COPD patients, spirometry demonstrates less marked improvement post-bronchodilator, as the damage to the airways is often permanent, attributable to chronic inflammation and structural changes in the lung. Thus, spirometry is an invaluable tool in the differential diagnosis, aiding in treatment decisions and management strategies tailored to each condition. Typical onset age, early life versus later in life. Asthma and chronic obstructive pulmonary disease, COPD, are both chronic conditions that affect the lungs and cause breathing difficulties. However, their typical onset age is an important factor for differential diagnosis. Asthma commonly begins in childhood or early adulthood, with symptoms such as wheezing, shortness of breath, and chest tightness often being triggered by environmental factors like allergens. In contrast, COPD generally appears in individuals over the age of 40 and is closely linked to long-term smoking. The damage from COPD accumulates over years, leading to a progressive decline in lung function characterized by persistent airflow limitation not fully reversible with medication, whereas asthma involves variable and often reversible airflow obstruction. Primary symptoms: intermittent wheezing versus persistent shortness of breath. Asthma and COPD, chronic obstructive pulmonary disease, share common respiratory symptoms but vary significantly in their onset and manifestation. Asthma is typically characterized by intermittent wheezing, often triggered by allergens, cold air, or exercise. It involves reversible airway obstruction and inflammation that can improve with medication or spontaneously. In contrast, COPD, which includes chronic bronchitis and emphysema, presents with persistent shortness of breath that gradually worsens over time. Unlike asthma, COPD's airflow limitation is not fully reversible and is often associated with a history of smoking. Diagnosing through spirometry, asthma shows a significant improvement in lung function after bronchodilator use, whereas COPD demonstrates less reversibility, reflecting permanent damage to the airways. This differentiation is crucial for the appropriate management and treatment of each condition. Inflammatory response: eosinophilic dominance versus neutrophilic dominance. Asthma is often characterized by an eosinophilic dominance in the inflammatory response. Eosinophils, a type of white blood cell, play a significant role in the pathophysiology of asthma by releasing mediators that cause airway hyperresponsiveness and remodeling. Conversely, COPD, chronic obstructive pulmonary disease, typically involves a neutrophilic dominance. Neutrophils release enzymes and reactive oxygen species that contribute to tissue damage, mucus hypersecretion, and impaired lung function. Sparingly, some COPD patients might present with eosinophilic inflammation, potentially responding to corticosteroids akin to asthma management. Spirometry can further distinguish the diseases. Asthma shows a significant reversibility in airflow limitation post-bronchodilator, whereas COPD demonstrates a less reversible obstructive pattern, reflecting the more permanent damage to the airways. Understanding the nuanced inflammatory profiles aids in tailoring specific treatments, improving patient outcomes, and potentially signaling the progression or crossover syndromes such as the asthma COPD overlap. Response to treatment: good response to bronchodilators versus limited response to bronchodilators. When distinguishing between asthma and COPD using spirometry, one key aspect is the patient's response to bronchodilators. Typically, individuals with asthma experience significant improvement in airflow following bronchodilator treatment, as evidenced by a marked increase in FEV1, forced expiratory volume in 1-second values. This response is due to the reversible nature of airway constriction inherent in asthma. In contrast, patients with COPD often have a limited improvement after bronchodilator administration. COPD is characterized by persistent airflow limitation due to airway and/or alveolar abnormalities that do not substantially reverse with bronchodilators, reflecting the chronic and more irreversible damage to the lung tissue and airways.